Dr. Mandar Muzumdar is, in and of himself, a walking advertisement for the Bridge Project and interinstitutional collaboration. He trained at Harvard and Stanford. He's a postdoctoral fellow in Tyler's laboratory. He is an instructor of medicine at Harvard Medical School and an attending physician in medical oncology at Dana-Farber Cancer Institute. He's also one of the featured contributors to our Public Galleries Image Awards exhibition. So in fact, the beautiful image that you can see on the program and that you can see in person in our gallery is his. He views pancreatic cancer from two lenses, that of the investigator and that of the clinician. Tonight, Mandar will share his clinical perspective on the challenges facing both patients and researchers battling pancreatic cancer. Oops.
Is this working? Should be. Thank you, Anna, for the generous introduction. So my role today is to give you a brief introduction to some of the gaps in pancreatic cancer care, after which you'll hear about two specific projects that try and address some of these challenges that we face in pancreatic cancer. 46,420. That's the number of patients, of new cases of pancreatic cancer that are expected in the United States this year. Sorry about that. It's not. So recent studies have suggested that actually the incidence of pancreatic cancer is rising, particularly in the past 2 decades. In recent years, that rate of rise has actually been 1.3% per year over the last 5 to 10 years. 39,590. That's the number of patients that are going to die of pancreatic cancer estimated this year in the United States. While we've made tremendous strides in improving the care of cancer overall, from 49% in the 1970s survival, 5-year survival to 68% in the 2000s, we've not made a significant improvement in the care of pancreatic cancer, from 2% in the 1970s up to 6% in the 2000s. Overall, pancreatic cancer remains one of the deadliest diseases in terms of cancer mortality, while accounting for only 2.8% of all new cases of cancer. It accounts for 6.8% of all cancer deaths. As such, it remains a significant challenge, my hope is to try and convey to you some of the gaps in the care of patients with pancreatic cancer, and to suggest some ways that we may be able to overcome this. So we currently treat pancreatic cancer based on the clinical stage of diagnosis. There are 3 clinical stages that we focus on. One is localized disease. The others are locally advanced and metastatic. In local disease, the pancreatic cancer is confined to the pancreas without local invasion into nearby organs, blood vessels, or lymph nodes, and no spread to distant organ sites. At this stage, we are able to surgically resect the primary tumors, leading to survival times of 20 to 24 months median, and 5-year survivals are 24%. While these numbers seem low, they're actually better than what we'd see in later cases of pancreatic cancer. In particular, locally advanced disease, in which the primary tumor has invaded into either local structures, including local organs, blood vessels, or lymph nodes. About a third of the patients that present to us will have this at diagnosis, and the median survival is about 12 months, with a 5-year survival of less than 10%. In metastatic disease, or disease that's spread to distant organs, about half of our patients will present with this at diagnosis, and the survival times are even worse, at less than 12 months and a 2% 5-year survival. The best chance for cure and the best chance for long-term survival is actually in identifying patients early with early-stage disease at a point in which we can actually provide surgical therapy. Surgical treatment for pancreatic cancer comes in two flavors, and it depends on where the primary pancreatic tumor is actually located. If it's located in the head of the pancreas towards the right side of the body, patients actually undergo a very significant surgical procedure called a Whipple operation. In this procedure, a portion of the pancreas as well as the gallbladder intestines are removed, and the bile duct and the stomach are then reattached to the intestines. This procedure actually takes the better part of an entire day and results in a significant recovery time for patients. If patients are fortunate enough to actually be diagnosed with pancreatic cancer in the tail of the pancreas towards the left side of the body, they can undergo a more limited procedure in which only the portion of the pancreas as well as the spleen is removed. Given the lack of disruption of the intestinal tract, this actually results in fewer long-term side effects and faster recovery. All patients who undergo surgical resection receive chemotherapy, but still, despite chemotherapy and complete surgical resection, relapse rates are high on the order of 70 to 80%. For patients that have locally advanced relapse or metastatic disease, the standard of care is actually to treat them up front with systemic chemotherapy. That is, drugs that are given in the vein and that are distributed throughout the body to all sites of disease that may reside within the body. The chemotherapeutic gemcitabine became the standard of care in 1997 after a landmark clinical trial in which it was demonstrated that gemcitabine was able to actually reduce symptoms in some patients, but the overall tumor shrinkage rate was less than 10%, and the overall survival rate was actually only on the order of 5 to 7%. It has taken nearly 15 years for us to improve on our first-line therapy of advanced pancreatic cancer. But two new therapies have been developed and approved, and these include the triple chemotherapeutic combination called FOLFIRINOX, as well as the combination of gemcitabine and nab-paclitaxel, an albumin-bound chemotherapeutic. Both of them have led to improved tumor shrinkage rates as well as prolonged overall survival. As you'll notice here on the right, though, these improvements in therapy do come with a cost, as patients do suffer from additional side effects, including lower blood counts, increased risk of infection, fatigue, diarrhea, nausea, vomiting, and nerve damage. Currently, the combinations of gemcitabine and nab-paclitaxel as well as FOLFIRINOX are now being tested in earlier stage disease in the hopes of trying to reduce relapse following surgery, as well as to try and make patients with locally advanced pancreatic cancer surgical candidates, which may improve their long-term survival. Still, survival in advanced pancreatic cancer, despite these therapies, is rare, so much needs to be done to decrease overall pancreatic cancer mortality. So how can we go about doing this? I would argue that we should apply what we've learned from reductions in mortality in some of the other major leading causes of cancer death, including those of the lung, prostate, cancers of the lung, prostate, colon, and breast, and try and apply those, the knowledge of those specific measures towards pancreatic cancer. Specific measures that have been used to reduce mortality in these other cancers include modification of risk factors that are associated with the disease, trying to develop an expanded screening program to identify cancers before they've fully developed, and identify and remove precancerous lesions, as well as to try and develop methods to identify disease early at a point where it can still be completely surgically removed. For example, smoking cessation campaigns in the mid-1900s have led to a decreased incidence of lung cancer and as a result decreased mortality. Expanded screening for colorectal cancer has also led to a reduction in mortality by removing precancerous lesions prior to them actually forming cancer. And though it's argued the PSA, or prostate-specific antigen prostate cancer, and its widespread use may have contributed in part to the decrease in prostate cancer specific mortality, primarily by identifying cancers earlier in the course of the disease. The problem with applying this to pancreatic cancer is that the risk factors themselves actually have a very small contribution to the disease. So while there are modifiable risk factors, including tobacco use, obesity, and diabetes, that have been associated with increased risk of pancreatic cancer in considerable studies, the actual overall effect and contribution to the development of pancreatic cancer for each of them is quite small. Genetic risk, or hereditary syndromes that are associated with pancreatic cancer, do increase the amount of risk of developing pancreatic cancer, but they only contribute to about 10% of all pancreatic cancers. A host of other risk factors have been associated with pancreatic cancer risk, though the evidence for them is not as convincing. I would argue that though we have knowledge of risk factors, actually modifying any one of these risk factors is likely to have a very small contribution in reducing pancreatic cancer development and mortality, though at the population level, reducing the prevalence of obesity or tobacco smoke may actually have impactful effects on overall pancreatic cancer mortality. The other issue with these risk factors is they have not been validated together in any sort of risk model that would help us identify which patients we should be pursuing screening with. Additionally, our current tests for diagnosis of pancreatic cancer are not super efficient for screening. We currently diagnose pancreatic cancer based on the development of symptoms and then perform CT scans, as shown here on the left, to identify primary tumors within the pancreas, as well as metastases to distant sites, including as seen here in the liver. Patients that have metastatic disease undergo a CT-guided needle biopsy to obtain tissue and examine the tissue biopsy under a microscope to observe whether there's cancer there or not. In patients who are fortunate enough to have disease localized to the pancreas, they can undergo an endoscopic ultrasound procedure in which a scope is passed through the mouth, snaked down to the duodenum. The tumor is visualized with ultrasound guidance, and a needle is then passed into the tumor to obtain tissue as well. While CT scans and endoscopic ultrasound with biopsy are extremely sensitive and specific for pancreatic cancer diagnosis, they're generally not effective screening tools because of their cost and invasiveness, particularly in the case of the endoscopic ultrasound. I would argue that it would be ideal to have a blood-based biomarker that would identify patients with pancreatic cancer early in the disease that could be administered more easily, be sensitive enough to pick up pancreatic cancer, and allow us to intervene in an earlier stage when we can remove the tumor by surgery. Finally, another challenge to diagnosing pancreatic cancer early is that symptoms often develop at a later stage. Localized pancreatic cancer generally does not have a significant number of symptoms, and if they do, they're usually nonspecific in terms of mild abdominal pain, weight loss, or fatigue. Many of these symptoms can be exhibited by other diseases. As the pancreatic cancer grows and locally invades structures, it can cause more specific and prominent symptoms that may key us into the diagnosis of pancreatic cancer. But usually at that time, the tumor has grown to a point where complete surgical removal is not possible. Some of the symptoms that we do observe with local invasion of pancreatic cancer includes obstruction or blockages of many of the different nearby organs, including the bile duct, which allows passage of bile stored in the gallbladder into the intestines to allow us to digest food. And when this is blocked, it can lead to a condition called jaundice, or yellowing of the skin, and an increased risk of infection. When pancreatic cancer grows and blocks the intestines at the duodenum, it can lead to nausea and vomiting. And when it blocks the pancreatic duct that allows digestive enzymes to pass from the pancreas into the intestine for digestion, it can interfere with absorption of nutrients and lead to diarrhea. Many of these symptoms, again, only develop late in the stage, late during the course of pancreatic cancer development, again impairing our ability to identify cancer early. So if we have significant challenges to prevent disease and diagnose early, I would argue that the best course to try and decrease pancreatic cancer mortality in the short term would be improving our therapies for advanced disease. And one of those approaches would to improve our therapy to shrink tumors in locally advanced cases, in which the tumor is not initially amenable to surgical resection, but after which treatment is provided, it allows shrinkage of the tumor to a point where surgery is then possible. That would potentially allow us to cure more patients and lead to longer-term survival. Current methods, including a combination of chemotherapy and radiation, only result in shrinkage to a point where surgery is possible in a small minority of patients. So this remains a tremendous gap in our clinical care of patients with pancreatic cancer. The other method in terms of reducing mortality rates and prolonging survival is to improve on our ability to improve on our drugs, improve their ability to kill cancer cells, but also improve on our ability to deliver those precise drugs to the cancer itself. There have been significant advances in other cancers that have used recent advances in genomics or genetic data to identify genetic drivers of cancers that can be targeted with specific drugs that block those drivers. For instance, in cancers of the lung, melanoma, as well as breast cancer, these are used widely and have prolonged survival in many patients and led to increased numbers of cures. In pancreatic cancer, we actually have a fair bit of knowledge on the frequent recurrent mutations, genetic changes or alterations that we see in these cancers, with 4 hallmark mutations or alterations that actually occur quite frequently in the disease, more than 50% of the time. And these are in genes including KRAS, P16, P53, and SMAD4. Unfortunately, there are no clinically approved inhibitors that target these specific genetic alterations, though significant research here and elsewhere is being done to try and improve on the availability of clinical inhibitors for these specific targets. Even if we had inhibitors that worked efficiently in pancreatic cancer, another major obstacle that we face is the significant barrier that non-cancerous cells, so-called tumor stroma and proteins, denoted here in blue, that surround the black tumor cells and create a barrier to drug delivery. On the right, we see that within the tumor, a drug that's labeled with a fluorescent green is not able to actually get within the tumor even though it's been delivered to this patient. And similarly, we do not see a significant amount of blood flow within the tumor that allows delivery of the drugs. So a paucity of blood vessels within the tumor and the blockage of the entry of drugs within the tumor by this microenvironment is a significant challenge. And the 2 talks you'll hear today will go about to try and address this stromal barrier to try and improve drug delivery. This drug delivery problem, this stromal problem actually confounds not only our ability to treat the disease, but also our interpretation of clinical trials. In other words, we're not necessarily sure if we don't see a nice response, whether the drug is actually good at killing cancer cells or it's just not getting to where it needs to be. So in summary, I hope I've conveyed to you that the significant problem that pancreatic cancer poses. It is the 4th leading cause of cancer death in both men and women. And its incidence is rising, and we've only made small improvements in mortality over the last 30 to 40 years. And as a result, a recent report based on extrapolating current incidence and mortality rates suggests that pancreatic cancer is on the rise and is going to become the 2nd leading cause of cancer death by 2030. We have seen some improvements in the treatment of advanced disease with 2 new options for our patients, but there still remain significant gaps in the care of patients with pancreatic cancer, and significant research and development is required to try and make strides in this disease. Thank you, and I'll take any questions.